Good evening, everyone. Welcome, and thank you for joining us for tonight's virtual UMiami Health Talk, a highly anticipated and very popular topic called the COVID-19 vaccine, What You Need to Know. It's brought to you, of course, by UHealth, the University of Miami Health System. I'm health journalist Ileana Bravo, and I will be your moderator for this evening's program, or your air traffic controller for all the many questions we have tonight. Our experts will address a variety of topics and answer your questions, of course, about the COVID-19 vaccine. We've received many questions in advance, and we wanted to process them and get them ready for this UMiami Health Talk. But we will answer as many as we can live questions, which you can also enter during the webinar with the Q&A feature at the bottom of your Zoom screen. You can locate it now. It's got two little thought boxes that say Q&A. We please ask you to not be very specific with medical conditions and things like that, so that our experts can answer things in a broader way. In a few moments, you're going to hear from two University of Miami Health System experts, COVID-19 Chief Medical Officer and Chairman and Professor of the Department of Medicine, Dr. Roy Weiss, and Dr. Susanne Doblecki-Lewis, Medical Lead of the Vaccine Task Force and Associate Professor of Infectious Diseases. Each of our panelists, of course, are going to speak on different vaccine-related topics and address your questions. So now I'm pleased to tee it up and introduce our first presenter, Dr. Roy Weiss.
Thank you, Ileana. And good evening, everybody. It's a pleasure to be here to talk to you about a topic that's near and dear to our hearts, the COVID-19 vaccine. Well, indeed, December 15th, 2020 was a day that will go down in history. It was a very historic day here at the University of Miami because it was when we first started to inject vaccines into our frontline healthcare workers. It truly represented the point in time where we could see the light at the end of the tunnel, of this very long tunnel of a pandemic. We're not at the end of the tunnel yet, but we're looking at the light at the end, and the vaccines certainly bring us there. Here are examples of three frontline workers that take care of our patients at UHealth on a daily basis, the patients that come in when they're sick with COVID-19. You can see on the left, Kimar Estes, a director of nursing in the emergency room and in our oncology care unit. Anthony Adenosio, he's director of food services and provides food to all our patients in the hospital, whether they have COVID or not. And then in order to keep our rooms as clean as they can and sanitary, Veronica Valdez represents the environmental service frontline people that are there at our beck and call in terms of keeping our patients safe. And so these are the individuals that really served on the front line and received the first vaccines. You may ask yourself, why do we even need vaccines? Why are they necessary? Well, you have to understand that the virus that causes COVID-19, the SARS-CoV-2 virus, is highly transmissible by the respiratory route. And when people get that infection, it can be very serious. Secondly, it can be transmitted by people who don't even know they have the virus, or before they become symptomatic with the virus. So they could be spreading it and you wouldn't even know about it. It can become endemic, meaning that it could reach a steady state, and a developing community or herd immunity, which we'll talk about in a minute, is very unlikely. And I don't need to tell you all about the significant economic and human impact this pandemic has had on all our lives. When we talk about getting vaccines, many people are reticent to do so, and we call that vaccine confidence. Here is a study that was just published in Nature on just last Friday, showing the difference between the public opinion about whether or not they would take a COVID-19 vaccine if it were offered to me this week in November compared to January. And you can see that the number of individuals in the red bar that strongly agree that they would take it has increased from approximately 30% to 40%. And most people definitely agree in about 60%. And we find that's true in our population. About 60% of the people will get the vaccine if when offered to them. There are still significant numbers of people who are worried about the side effects of the vaccines. And we're here tonight to tell you not to be concerned about them, that it is a safe and effective vaccine. And you can see that the numbers of people that are strongly agree that they're worried about the side effects between November and January have decreased. And that's mainly due to the fact when it first came out, or even November was before it was even available, people didn't know what to expect. I love this as sort of an introduction to give us a sense of what we when we think about the concept of herd immunity. It's a known fact that sheep that give us steel wool will have no natural enemies. So what do we mean by that? What do we mean by herd immunity? Bear with me for just a second. Let me give you 3 scenarios in this slide. The little people that you see there, colored blue, are people that are immunized and are very healthy. And the people in red are people who are indicative of those that haven't been immunized but are sick and can pass the virus on. They're contagious. And if no one in that cohort, in that herd, if you will, is not immunized but healthy, and just 2 people get it, when no one is immunized, the disease spreads throughout the population. And here you can see the disease spreading through multiple individuals now colored red. On the other hand, when some of the population is immunized, those are the people now in yellow that they're immunized, and the disease spreads by the same 2 people, it will still significantly spread to those that were blue, those that were healthy, but not immunized. So that's just if there's a small number of gold people that were immunized. But on the other hand, when most of the population is immunized and most of the people are gold, and you have a few healthy people and still the same 2 infected people, what happens then is this is the concept of herd immunity. That means most of the people will not get the virus. Even the blue people will be protected because the majority of the people will get it. Some will get it, but most will not get it if the majority of the population is immunized. And what's that number? What's that magic number when we might be able to lessen our defenses and become less fastidious about wearing masks? That's when we get to 85% of the population. Right now, we're about 2% of the population being immunized. So herd immunity is the indirect protection from an infectious disease that occurs when a population is immune through vaccination or previous infection. Herd immunity threshold for this virus is probably between 70 and 85%. The challenges to achieving herd immunity is this vaccine hesitancy, which I mentioned to you, the unknown role of vaccines in preventing transmission. We know vaccines are very effective in decreasing the severity of the disease, but will they decrease specifically transmitting the disease to someone else? We know that there are new variants that Dr. Doblecki-Lewis will talk about in just a minute, and the spread of those new variants enters another factor or unknown, and the waning immunity over a period of time, immunity lessens. So herd immunity is something that we can't necessarily count on. So what are these vaccines anyway? What are they made of? And so the 2 vaccines that we have available in the United States today are the Pfizer vaccine and the Moderna vaccine. And these are known as RNA vaccines. What's an RNA vaccine? Well, you see this little baseball-like structure here in blue, and it's surrounded by a lot of little dots. And those dots are little fat droplets. We call them lipid droplets. And they form the boundary of something called a nanoparticle. And those of you that are interested in the manufacturing of vaccines, the lipid droplets is the most crucial and limited supply that we have in order to make these vaccines. So getting that has been a challenge. But once we've gotten these little lipid particles formed, inside of them is a small strand of something called RNA. RNA is the blueprint for all the proteins in the body and any protein that anyone could ever manufacture. So a bunch of these little baseballs are put together in a syringe and injected into your deltoid muscle, into your arm muscle. When they get into your arm, into your muscles in the arm, these little baseballs fuse the lipids with the membranes of the cell, and then that RNA is released into the cellular cytoplasm, where it utilizes the machinery already there to manufacture a viral specific protein that is only present in the SARS virus, the COVID virus, so that then the immune system recognizes this protein as foreign and gets really revved up, and the immune system gets all prepared to fight that virus once it comes into your system and you meet it. It's like a boxer in a boxing ring getting ready to fight. And finally, when the opponent shows up, the SARS-CoV-2 virus appears, the immune system is all set, ready to go, and to destroy the virus. This is a RNA vaccine. Other vaccines would utilize DNA directly in a viral particle that the virus has been weakened and doesn't replicate and is attenuated. And instead of going through the RNA, the DNA goes into the cell, makes its own RNA, makes it to specifically the same proteins, and an immune response is generated, which then allows for immunity to occur. And the third type of vaccine is we don't give you RNA, we don't give DNA, but we just give you the protein itself. And we inject the protein into the blood. This stimulates the immune system. And when the protein comes around, or when the virus comes around, the immune system is all ready and ready to fight. The problem is that these protein-based vaccines don't last very long. They have to usually they have to be injected several times in order to get the amount of protein there, and eventually the proteins sort of wither away, and you have to get vaccinated again. So there are actually, therefore, three types of vaccines. There's the RNA vaccine, the adenovector virus vaccine, and the recombinant protein vaccine. So the two that we have available right now is the Moderna and the Pfizer vaccines, and those are the ones that we were given, and I'll explain how we get them, at UHealth, and they're very effective against symptomatic disease, and they're approved by what's called an EUA, Emergency Use Authorization, from the FDA. The FDA approved this for an EUA. This is on probably December 12th or 13th it was approved, and we got them on December 15th. These are the vaccines that are available in the United States today. You might have also heard that Johnson & Johnson, or the Johnson vaccine, will be presented to the FDA probably the end of this week, and those will become available soon thereafter, along with Astrazeneca. These have a little bit less number of efficacy, but just to give you a comparison, the flu vaccine is approximately 40 to 50% effective against the flu. So this is a little bit more than that, and certainly the Moderna and the Pfizer are. And lastly, the protein vaccine that I talked to you about is Sanofi and Novavax. Those are the two companies that are making those. And you might have heard about the use of these vaccines in South Africa and in Europe, where they're being used today. We don't exactly know when those will be approved for use in the United States. So in terms, going back to the RNA vaccines that we have, the Moderna and the Pfizer, those were manufactured by the companies in various parts of the world. Then the United States, the federal government, purchased these vaccines and kept them in storage until the government approved, the FDA approved the use. And then, quick like a bunny, they distributed these vaccines to the various states of the United States. So each state got a certain allotment of vaccines. It's not entirely clear how the number of vaccines that were purchased by the federal government were given to the states. So the state of Florida got a certain allotment of vaccines. And then it's up to the state to distribute those vaccines to hospitals, to nursing homes, pharmacies, and other healthcare facilities. And so the healthcare facility has absolutely no say or line of sight as to how many vaccines they get or when they get it. It's totally up to the state, and the state has not much say in what the federal government does. Now, we have, 300 million plus adults in the United States that would need to be vaccinated. And so the federal government put a priority score, if you will, for who should get the first set of vaccines in the first phase and who should get them in the subsequent phases. And you can see that the number of individuals first were 1A were healthcare personnel, long-term facility personnel, initially persons greater than the age of 75, then 65 to 74, and then 16 to 64 with high-risk medical conditions, etc. But here you can see the number of millions of individuals. Clearly not enough vaccines to go around. And we have at the University of Miami 20,000 employees and 3.5 million patients, and we got about 20,000 or 20,000 vaccines. I'll explain a little bit more. So how do we decide who gets a vaccine first and who gets it second? And please understand, ultimately, everybody that wants a vaccine will get them. They can't be made mandatory because they're still under FDA investigation and what we call an EUA, but sufficient data to know that it's safe and effective. So we followed the guidelines of the National Academy of Medicine and the CDC's Advisory Committee on Immunization Practices for ethical principles. And so we had three basic ethical principles to decide how to distribute the vaccines. First, the basic ethical principle is you have to maximize benefit and minimize harm. Save the most number of lives you can save, reducing morbidity and maintaining society to function. The second is to promote justice, protect and advance equal opportunity for maximum health and well-being. And thirdly, mitigate health inequities, reduce existing healthcare disparities to strive for health equity, and to promote transparency as the overriding meta principle as to what we do, to make sure that it's communicated to everybody how we give these vaccines out. And we developed an advisory committee to help us determine how we would prioritize these vaccines within the confines of the federal government and the state government's requirements. And sometimes the federal government and the state government didn't actually agree. So we have an adult physician and pediatrician as well on the committee, advisory committee, our own Susanne Doblecki-Lewis, who you'll hear from in a few minutes, the head of our ethics center, Dr. Goodman, Dr. Parekh, our chief operating officer, and Dr. Maritza Suarez, our chief medical information officer, as well as a group of individuals who are expert administrators. And so how did we allocate the first set of vaccines that we got? I told you we had 20,000 UHealth employees and 3.5 million UHealth patients. So with regard to the employees, we identified who they were based on their job descriptions, whether they were frontline workers or non-frontline workers that had high comorbidities and age. And then we did the same with the UHealth patients. With 3.5 million, we had to start reviewing their medical records electronically based on their age greater than 65, because that's the major risk factor, 2 or more CDC comorbidities, and been having seen here in the last year, and that they have my chart. So those were 8,000, for which we had about less than 1,000 vaccines initially. And so we assigned everybody a number randomly and then had a lottery to decide who would be in the first wave. Then we had a second wave, the same as above, but maybe only one CDC comorbidity, and a third wave that had the same as wave 1 with multiple comorbidities, but maybe didn't have the advantage of an electronic medical record or email or other things. And so we called those individuals on their home telephone number to invite them to make an appointment. And those of you that are in the audience that have gotten a vaccine here at the University of Miami, I hope can attest to how smooth the situation was once you came for your appointment. Nobody, once they had an appointment, was turned away, and everybody was in and out usually within 25 minutes from the time they registered to the time they left, including the 15 minutes of observation. In addition, there were many community healthcare providers who didn't have access to vaccines, who, when we had sufficient vaccines, we were able to prioritize those. Subsequently, the CDC has also defined these as the high-risk conditions, and I won't go through all of them, but you can see these are the things that when people get COVID-19, they end up being really sick if they have this as what we call a comorbidity. And the next groups that we started were those that were less than 65 of age, but still had significant comorbidities, and some of which may not have been included by the CDC. Although we have very, very limited vaccines, and in fact, we haven't had any vaccines available for 2 weeks, we are hoping to get some soon, and when we do, we will continue where we left off. So while the vaccine is likely to start stimulating antibodies soon after injection, don't think you're Superman or Superwoman after you get this vaccine. We don't know when the antibodies are fully protected. We don't know how long they'll last. And we don't exactly know whether or not, once you're vaccinated, whether you'll be able to give the virus to somebody else. We do know that you're not going to get sick with the virus as likely as if you didn't have the vaccine. So please, please, even if you're vaccinated, continue to wear a mask, keep distance, social distancing, and practice good hand hygiene. And when the time comes for you to get a vaccine, please remember that a vaccine will only work if you take it. Thank you for allowing me to give this very brief introduction to vaccines. And it's my pleasure at this moment to introduce Dr. Susanne Doblecki-Lewis. Dr. Doblecki-Lewis, in addition to being one of the world's experts in infectious diseases, has also been one of the major investigators of the Moderna vaccine trial at the University of Miami. So it's my pleasure to introduce Dr. Susanne Doblecki-Lewis.
Thank you, Dr. Weiss, for that very kind introduction. The goal of my slides is just to cover some of the basic clinical information about the vaccines that we have and the vaccines that we're giving now at UHealth. And then to answer some of the common questions or common pieces of information that people would like to hear before we go ahead and address your questions that are coming up in the chat. And I see as I'm looking at the chat that there are quite a few questions, so we'll try to get to those as soon as possible. First, this is kind of a recap from Dr. Weiss's slides. Thinking about the vaccines that we have available to us today, we do have the 2 that are currently in use here in the United States. Those are the Pfizer vaccine and the Moderna vaccine. They're actually quite similar, as Dr. Weiss was discussing. They're both mRNA vaccines and both require 2 injections. One is 3 weeks apart, the other is 4 weeks apart. Otherwise, there are very few differences between these 2 vaccines, and we can talk more about that as we go. we, as you know, and as I'm sure you've heard in the news, are supply limited on vaccine right now. So we have far more people who are anxious to get the vaccine and who definitely could benefit from the vaccine than we have vaccine available. It's very exciting to know that there are other vaccines in the pipeline. The one that's most likely to become available next would be the Janssen vaccine. And this will be reviewed by the FDA's review panel on February 26th. So based on the timing of our previous vaccine approvals, we'll expect, if all goes well, that very soon after that, we may have this vaccine available as part of our armamentarium against COVID-19. The advantage of the Janssen vaccine is that it is one dose, as opposed to two, and it has some other advantages like not requiring super low temperature freezers for storage. So it should make things much easier in terms of being able to get the vaccine out through regular clinics and doctors' offices, pharmacies. So we're really looking forward to that and hope that it will accelerate our ability to vaccinate our patients. And then the Astrazeneca vaccine, which is a little bit further behind, but still has data coming in, and we're expecting that in the next couple of months, they will also be applying for an EUA in the United States. So there's a lot to look forward to, and I think we've seen some acceleration in the rate of vaccine. We definitely have over the last month, and I expect that we will continue to see that more acceleration and more availability of vaccine in the coming months. So everyone is asking about the variants. So let's talk about the variants for a moment. There has been a lot made of the variant that emerged first identified in the United Kingdom. And then subsequently, we've seen other variants in South Africa and Brazil and really all over the world. So, you know, one thing to know about variants is that they're kind of expected when you're dealing with a virus that's replicating actively. We know about viruses that they do over time change a little bit as they get passed from person to person. So this is an expected thing in a way, and something that we're going to continue to see. And certainly we will see variants emerge everywhere. We are still learning about the characteristics of the variants. We have some reassuring news that the UK variant that was identified does respond or is blocked by the currently approved vaccines based on tests that have been done to date. This is something we're keeping an eye on though, because as you may have seen, some of the other variants are a little bit less susceptible to some of the vaccines, and we may indeed need to tweak things in the future to address these variants. But I think one of the key points about the variants is that variants emerge when there's a lot of circulating virus. If we can get ahead of this with vaccine that we know works right now in the United States against the strains that are circulating in the United States, we will decrease the amount of virus out there and therefore decrease the number of variants that are emerging. So it's critically important that right now, especially, we get ahead of this by getting vaccine out as soon as possible. Another point is that even when in some of the variants that have popped up in different places, not here in Miami so far, there may be some reduction in how well the vaccine works. It still does protect quite well against severe disease. So I think, you know, there's still a lot of benefit to getting vaccine in many, many ways. And variant strains are one reason to even be as aggressive as we can about getting vaccine out right now. Okay, so let's talk about side effects. So right now there's about 30 million people in the United States who've received these mRNA vaccines. And it's actually quite remarkable how few serious side effects have been seen. So really the side effects that we do see and that are pretty frequent are the ones that you might expect after receiving a vaccine. So that would be pain in your arm, sometimes swelling at the site of injection, and really this kind of low-grade, not feeling great sensation that we've all had probably after having vaccines before. So this could be low-grade fever, sometimes chills, fatigue, headache. And we have seen that these symptoms are more pronounced after the second dose, but still they do go away in a couple of days and are generally not serious or dangerous in any way. So this is actually kind of a good thing. It's your body making an immune response to the vaccine. So it's expected. The vaccines, none of the vaccines contain any live COVID virus, and they absolutely cannot in any way cause COVID. So the symptoms that you should not expect to get as a result of the vaccine are things like cough, sore throat, runny nose. These are symptoms of COVID. And unfortunately, because there is a lot of COVID out there, there's nothing that says you can't get the vaccine and on the same day get COVID. It does take some time for your body to produce protective immunity to the virus. So I say that as a little bit of a cautionary note because we have had people who had symptoms after the vaccine that they thought might be related to the vaccine, but actually it was more likely related to COVID that they had acquired and didn't get the vaccine in time to prevent. So then some specific populations where we get frequent questions about considerations for the vaccine. For people who are nursing or who are pregnant, the CDC and the FDA have made the decision that women may make their own decision about receipt of the vaccine. There's no contraindication. And this can be a discussion between a woman and her provider or her own decision about risk benefit. What this means is if someone is in a situation where because of their occupation or other exposures, they are highly likely to be exposed to COVID, we know that women who are pregnant often have worse symptoms of COVID, more likely to have severe COVID, and can have complications of their pregnancy if they develop COVID. Therefore, the vaccine may be a much less risky choice. We have no data to suggest that there is any harm to pregnant women or to a developing fetus. Animal studies have been reassuring. However, there are not human trials that have specifically looked at vaccine for pregnant women. So for this reason, it's really a decision that a woman can make on her own, but the guidelines right now are supportive, meaning that the choice that she makes is supported by the FDA and the CDC, and she can choose to receive the vaccine if appropriate. So what about if you took part in a COVID-19 vaccine trial? That's great. That's how we have the data that we are presenting today, and that's why we have vaccines available. So thank you for participating in a trial if you did. It's important to contact the trial site to get information about how to proceed. In no case are people who are indicated and able to receive vaccine under emergency use prohibited from doing so because they're in a trial. But it's important to coordinate with the trial site to make sure that that is done in a safe way, if that's the choice. And many trials now, once the vaccine becomes approved, then go ahead and give the vaccine to everyone in the trial. Also, there are ongoing trials still. So Dr. Weiss mentioned the Novavax vaccine, which is still in active clinical trials that are recruiting. And if you're someone who may not have a strong indication for getting the vaccine in the near future, you may want to look into participation in a clinical trial as a way to contribute, and also potentially a way to get the vaccine a little bit earlier if you're lucky enough to be randomized to the group that receives the vaccine. What about people who've had COVID-19 already? So in the United States, the people who've had COVID-19 and fully recovered and who are out of quarantine may go ahead and receive the vaccine. And it is recommended that they eventually do so. There's no rush to do so immediately after a COVID-19 diagnosis. We know that natural immunity after a diagnosis of COVID-19 lasts at least 3 months, probably quite a bit longer than that. So, it makes sense to wait and give others who don't have protection a chance to receive the vaccine first. However, there's no reason that someone who's had COVID-19 and recovered can't receive the vaccine in the future. And it's thought that it's a good idea because it does boost the antibodies and provide a stronger response that's likely longer lasting. So it is recommended to get the vaccine, but again, there's no rush, and you would want to be fully recovered from symptoms and out of quarantine in order to receive the vaccine. I think that's the end of my slideshow.
Excellent. Thank you. Thank you so much, Dr. Doblecki-Lewis and Dr. Weiss. It was very comprehensive, and all the information is probably covered all the points. However, we still have a lot of questions and perhaps a few points that we'd like to even reiterate more so. So let's get right to it. Our first question of the evening for Dr. Weiss is, and I know that Dr. Doblecki-Lewis just went over this, but can I get the vaccine if I've had COVID-19? And let's make it a two-part. How long after having had COVID should I get the vaccine?
Yes, people should still get the vaccine, even if they had COVID. The question is, when is the right timing for that vaccine? Because once you've gotten the infection, you have developed some antibodies, but they're not necessarily the strongest of antibodies, depending the type of the degree of the infection that you had. So generally speaking, you cannot be in quarantine or in isolation and get the vaccine. So it should be after you've passed at least the 2 weeks, and probably you're okay to wait up to 3 months to start the vaccine trial, rather to get the first dose up to 3 months, because we believe that the immunity is at least there that long, and it will give other people who haven't had COVID-19 the opportunity to get the vaccine, because you may not necessarily need it. Now, so it could be anywhere from 2 weeks to 3 months. Also, it is sometimes what happens is that you get the first dose and then you get COVID-19, because the first dose wasn't completely effective as we know. And the question is, when do you get the second dose? So indeed, you should not get the second dose before the 4 weeks for Moderna or the 3 weeks for Pfizer, but you can delay the dose up until you're out of quarantine or isolation, and you no longer have any symptoms. And that's true as well. You should have absolutely no symptoms when you go for your vaccine.
Okay, thank you for clearing up. That was a twist we hadn't thought of, so thanks for covering that. Dr. Doblecki-Lewis, now here's for you. If you get the flu shot and you're called to get the COVID-19 vaccine, or for that matter, if you get the shingle shot, because I know that this is another one, is it okay to get the vaccine a few weeks, a few months later? What's the thinking on that?
Sure. The recommendation right now is that if you can separate two vaccines by 2 weeks, then that would be preferred. The main reason for doing that is because other vaccines also do have side effects, similar overlapping side effects with sore arm and feeling a little bit lousy for a couple of days. And it's sometimes hard to suss out what is causing what. So that's really the main reason for it. And also in the clinical trials, they did ask people to separate vaccines. So we don't technically have data on combining them. It's really a theoretical risk. It's not thought to be a significant one, but the main recommendation right now is just to wait 2 weeks and then go ahead and get the vaccine as soon as you can. And right now, I would say that given the pandemic and how much virus is circulating, the COVID vaccine should generally be the priority. So if the question is, should I get the flu vaccine and wait 2 weeks and get the COVID vaccine, or vice versa, I would go with the COVID vaccine first.
And while I have you here, I want you to reiterate this point because this question addresses it. If a woman is nursing or pregnant, should she wait to get the vaccine? I know we often think we hear things, but we need to hear them again.
Sure. So it really is a personal decision. So as I was mentioning, all of the guidance suggests that if a woman chooses to get the vaccine while pregnant or nursing, then that is absolutely supported. And there are good reasons to do that. For someone who is able to shelter at home and who really doesn't have any occupational risk and maybe a bit concerned about getting a vaccine, any vaccine during pregnancy, it's reasonable to wait. So that's the kind of personal decision that each woman would make. However, again, the data that we have, the way that the mRNA vaccines work, there's no suspicion that this would be dangerous. They do not incorporate into DNA. They do not enter the nucleus of the cell. They actually last a relatively short time. They kind of come in, produce the protein that makes the immune response, and go away. They naturally break down in the body quite quickly. So there's no reason to suspect that this would be dangerous. The American College of Obstetrics and Gynecology is also supportive of women's right to be vaccinated during pregnancy or during lactation if she chooses to do so. And the animal studies, as I said, are also supportive, but ultimately it's a woman's own decision, can be in coordination with her providers.
Okay. And Dr. Weiss, since your colleagues just addressed the fact that the vaccine does not affect DNA, let's talk about that a little bit more. And also, along with this question, should someone with an autoimmune disease or other conditions such as severe allergies choose to take one brand of vaccine over another?
Of the two vaccines that are currently available whether or not you have an autoimmune disease or not doesn't influence which vaccine you should get. You should get the one you can get your hands on first. That's what you should get. In terms of as Dr. Doblecki-Lewis eloquently stated, this does not affect your DNA. This does not affect you. This is not the government putting GPS molecules into your blood so they can follow you wherever you go. That magical thinking is totally erroneous and false. And unfortunately, some people tend to believe this magical thinking, and it makes it worse for everybody, because until we get the vaccination rate at that 75 to 85% that we mentioned, we're not going to have herd immunity, and we're still going to be having prevalence of the infection and variants in our community.
And along the lines of allergic reactions, this whole thing of autoimmune disease and other conditions like that, and people with food and medication allergies, let's talk about that, because again, this is an obstacle for people.
Sure. And there's nothing scarier than having had a reaction once and wondering, my gosh, I don't want to have another reaction like that ever again. So first, let me preface this by saying, check with your doctor before you get a vaccine. If you have any questions or any hesitancy, because your doctor knows your history better than anyone else, or whoever your healthcare provider is, if it's if not a doctor, a nurse practitioner, whoever it is, consult with them. There's none of us on a webinar is going to be able to give you medical advice you can take to the bank or to a lawyer. So let me just say, check with your doctor. Having said that, most of the allergies that people have to vaccines aren't necessarily the substance of the vaccine itself, but necessarily some of the incipients or the preservatives that are used to stabilize the vaccine. So people that are allergic, like, or have reactions to glycerol, or to in some of the older vaccines, it was egg. If you were allergic to eggs, they asked you, but some of the virus-based vaccines were grown in avian eggs at some point. So there may be some small amount of antigens that people could react to. In general, the vaccines are very safe. If you're somebody that is highly allergic to various things and had a significant reaction in the past to the flu vaccine or another vaccine, please, before you go for your vaccine, check with your physician to be sure that it's okay. Most of the time, it is okay. And if you come to UHealth for your vaccine and you tell us that you think you may be at risk, but you want to get the vaccine anyway, rather than observing you for 15 minutes that we generally observe all our vaccinated patients for, we will ask you to stay for another 15 for 30 minutes so that we can observe you. I'm not so sure how that's done in these drive up and drive by vaccine stations. And I'm not commenting that those aren't good or safe to do. I'm sure they're perfectly safe. But if you're a type of individual that knows that you have significant allergies and are still going to go ahead and get the vaccine, it's important to let the people know who are administering the vaccine that that may be a possibility.
Yeah. And unfortunately, people desperately trying to get them are going to these mass vaccination sites for that very reason, because there's just no availability. But Dr. Doblecki-Lewis, let's talk about women again. Are there any concerns about the vaccine negatively impacting sperm, well, in this case, men and women, or egg viability post-inoculation?
The answer is no. And thank you for asking that question, because I know that this is something that is circulating on the internet quite widely. But to be very clear, there are no data behind this. There's no science to suggest that this is the case. And really, again, based on the way that the mRNA vaccines work, and I think when people hear RNA and it's, sort of genetic material, it sounds scary, but it's not genetic material like your genes. It's a little bit of sort of the message that doesn't even get into the part of the cells where the genes are kept, and does not interact there or change genes in any way. And there is also, I know with some things that are on the internet, there's no cross-reactivity with the placental proteins or endometrial proteins. Those kinds of things are not based on the science, and have been looked into, actually. So these really are in the category of rumors, but not based on science. But I think it's important that we address these things. I mean, it's true that the mRNA vaccine is a new technology. Although it's been in development for some time, these are the first times that it's actually been rolled out in a vaccine that's been given to us to protect from disease. So it's reasonable that people have questions, and I think it's important that we address these questions. And that one in particular, I've heard very frequently, and I'm pleased to say that there really are no data to suggest that that is the case.
And that's why we're here tonight with the best in the business, right? To discount these urban legends, if you will. So Dr. Weiss, here's one that we hear a lot too. Can you take two different vaccine brands for your first and second dose? And let me piggyback off of that. In the future, when the boosters are developed, will we have to continue with the same brand?
So right now, the thinking is that you really need to get your booster from the same manufacturer that you got your initial vaccine from. And the reason for that is, although Pfizer and Moderna are both RNA vaccines, they're slightly different in terms of the protein part or of the virus that your body is making antibodies to. So in order to maximize the effectiveness of the vaccine, you want to be sure that the booster is really boosting the first one. So the first and the second one should generally be of the same, from the same brand. Now, having said that, there have been reports by many prominent vaccinologists and immunologists that suggest by mixing and matching that you might be able to be more effective against some of the variants. However, there is no data to support that at the present time, and that it really is important to get your booster, especially for the RNA viruses that require boosters. As Dr. Doblecki-Lewis said, the J&J Janssen vaccine is only one, so it won't require a booster. Let me also add to this, Ileana, although it's sort of part of a corollary to this question, is people ask us all the time, well, I got my first dose at Mount Sinai, but I really don't want to schlep all the way over there, so I want to get the second dose at UHealth? Can I go to one place for the first dose and another place for the second dose? And the answer is no. You can't do that, because the way the vaccines are distributed to the hospitals and the healthcare facilities are such that whoever gets the first dose, we are assured the quantity to give to the second dose. And the state keeps very careful records. Everything is transmitted at the end of the day is with your driver's license or ID number, who got what vaccine, what lot number, etc. And so you can't go to, for example, it's like going to one shoe store and say, give me a left shoe, and then going down the street to another shoe store and said, I want to buy the right shoe from you. Well, the shoe man's sitting there with one extra right and one extra left. He can't do that. So what you really need to do is you must get the same manufacturer vaccine, and it needs to be in the same location. And I know this is sometimes difficult because people, let's say I was in Boston and I got the thing in Boston, but then I moved to Miami in the 3 weeks. So can you give me the dose? Unfortunately, the state won't allow us to do that. We don't have the doses available.
Yeah, and we have to have some control over the data. So you're absolutely right. Thank you for reiterating that. And now the question on children. Because I know that some of the criteria you said are from 16 and above in certain comorbidities. And now when can we expect children of any age to get vaccinated? Dr. Doblecki-Lewis, you can take that one.
I'm definitely waiting for this one as well. I can't wait to get my children vaccinated. So far, I'm the only one in my family who's vaccinated. Yes, so what we know about the vaccines right now, the Pfizer trial did go down to age 16. And for that reason, the Pfizer vaccine is approved for everyone 16 and over. The Moderna trial only studied from 18 and up. And for that reason, Moderna vaccine is only available to those 18 and up. Pfizer has enrolled participants 12 and up in their vaccine trials and have some data on folks who are 12 and up. That will probably be the first younger group that we see, still a few months away for sure. And these things are always uncertain. So we'll see when Pfizer requests approval for those 12 and up. Moderna is now also doing a trial for adolescents, and so we will also expect data for adolescents shortly for the Moderna. When I say shortly, I mean in the next few months for Moderna. For children under 12, studies are planned and beginning, but are still in the early stages. Now, these studies don't need to be as large as those that were done for the initial approval in adults. So rather than 30,000, 40,000 participants, you're looking at more in the 3,000 to 5,000 range, because we do have a lot of data from the adult trials, and it's more about looking at dose and looking at antibody responses and safety. So the hope is that we will have approvals for younger children. I think we all hope by the fall for obvious reasons. And that looks like the time frame that's happening right now, late summer, early fall.
Great. Dr. Weiss, obviously someone was listening, because this question said, you said that we are only at about 2% of immunized population. Does that encompass people immunized by vaccination only? And if so, why can't we count on people who have been immunized by previous infection? Now, there's an interesting one.
I wish my students would listen as well as the people who are doing. Excellent. So the idea is that we can't really, on the long run, we can't really count those that have been infected, because we don't know how long that immunity lasts for, or the degree of infection. So some people might have gotten a little bit lesser of a virus load than another, and so therefore their immune response may not be as strong as someone who got a higher load. But when you get the vaccine, you get a standard amount of load, so to speak, or of virus response, or neutralizing antibody response, we hope. And so it's for that reason that we probably wouldn't want to count the people that have been infected overall, although it does contribute in the immediate range to controlling the virus.
And then, Dr. Doblecki-Lewis, how about how long does the vaccine protection last? I know we don't have a definitive, but what's the data saying?
Sure. So we don't have a definitive because the virus itself has only been around for about a year and a month, maybe. And the vaccines, obviously, for a much shorter period of time. But we do know that there's strong protection for 3 months. The way that the antibodies look over time suggests that we've got at least 6 months. But that we'll have to wait for the clinical data on that, and probably longer. Just based on what you can see in terms of how strong the antibody response is and how not quickly it's going down over time. So I think that, we will learn more over time. Like you said, it's just too soon. We can't know until time passes. Also, for the Pfizer and the Moderna trials, participants are still in those trials. Even here at UHealth, we have a site for the Moderna trial, and we're continuing to follow our participants. They've all been vaccinated now, but we are periodically drawing blood. We're following them for development of any symptoms. And through those trials, we will learn a lot about how long protection really does last. And of course, as soon as we know that, that will be reported out so that we can apply it. And then we'll look into things like, do we need boosters or not? That kind of information will follow.
Yeah. Dr. Weiss, this should be a good problem to have when we have multiple vaccines, hopefully soon. How will we decide which vaccine to get?
I don't think there'll be a lot of choice. In other words, I think it will really depend on what is distributed in your area and which one you can get your hands on first. As far as we know now, there in the pharmaceutical industry and in medical research, there's called head-to-head trials where you can compare one vaccine to another. We're not near to that point where we can compare efficacy in a scientific way of one vaccine to another. In general, whatever vaccine you can get is the one you should. We don't know what the timeline will be, but we hope that everyone by summer and certainly fall that wants a vaccine will be able to get one.
Yeah. And I think our take-home message, if the two of you could just give us a little wrap-up. Two key things that you were talking about is whether the boosters being developed are going to address the variants of COVID, and also please bring home this message again. Although you get the COVID-19 vaccine, that does not mean that you can't still be contagious or spread it or get infected yourself, right?
As for the variants, there are tweaks to the vaccines that are currently underway. Both Pfizer and Moderna, as well as some of the other vaccine manufacturers, are looking into it. So I think the point here is to be prepared. Right now, the vaccines that we have are vaccines that work. But the future is, as we've learned from the pandemic, always uncertain. And it's important to look forward, and that is happening now. So those whether we'll need a booster to address variants in the future, it's possible, and that's being looked into and being studied. So I think that's one of the key points. And now I've forgotten the other key point.
No, and Dr. Weiss can bring us home with this too. Speak to us like your master students, and and tell us what our take-home message is tonight from all this great information we've gotten from you.
I think the take-home messages is that life is great. The science and industry that have come together to produce a vaccine in record-breaking time. And although there's bumps in the road in getting the vaccine out to everybody, it will go out, and it is effective, and it is safe. And there is hope that we will see the end of this pandemic, God willing, very soon. But for now, we still need to be cautious. Still, please wear masks, don't be reckless, and keep physical distancing when possible.
Thank you. I'm so glad that that's the final message for the evening, because we all think that this vaccine is the surefire, that's it, and then we can live life freely, and it's not quite there yet. So thank you to our two incredible experts. You were magnificent. We thank all of you in the audience for joining us tonight. And just remember that UHealth is here to care for you in person or virtually, whatever your choices are. Visit umiamihealth.org to get the latest COVID vaccine information for UHealth patients, and much more news and information about the COVID vaccine and coronavirus by checking out news.umiamihealth.org. There's a lot of information, a wealth of content on that website for you to stay informed, because knowledge is power, and that's how we're going to get through this. So we hope you enjoyed this presentation tonight. Please complete the survey at the end so we can know what other topics you'd like to hear about. And we wish you a very safe and wonderful evening. Good night, everyone.